Hello, and welcome to the Pulse of Manatee, brought to you exclusively on Manatee Educational Television. I'm your host, Dr. Shrini Iyengar. I'm an interventional cardiologist at the Braden Cardiology Center, and today I want to talk about diabetes. Believe it or not, diabetes increases your risks for many serious health problems. But there is good news. With the correct treatment and recommended lifestyle changes, many people are able to prevent or delay the onset of complications. We have an excellent panel here today to discuss the many complications stemming from diabetes. To my left, we'll start with Dr. Bob Kozer, primary care physician here today to talk about the management of diabetic complications as well as the diagnosis. To his right, Alyssa Zanchevitz, podiatrist, to discuss the complications of diabetes in extremities. To her right, Paula Jefferson, who is currently the nurse and as well as head of the Heart and Vascular Center at Manatee Memorial Hospital. So guys, let's start the topics off. Bob, first and foremost, diabetes. People think it's just high blood sugar. How do you explain to a person when they're first walking into your office that it's a lot more than just high blood sugar?
Well, the typical patient that I see in my office with diabetes will be a middle-aged or an elderly patient that comes in. They're usually overweight. They don't exercise enough, their blood pressure is a little bit high, their cholesterol is a little bit high. And when I tell them that they have this the disease of diabetes or they have insulin resistance syndrome, they usually get defensive and say, I don't even eat that much sugar. So the first thing that I have to do is educate these patients that it's not a sugar-eating disease. It's an insulin and sugar metabolism disease.
And to everyone at home, to really wondering the description, insulin is produced by your pancreas in your body, regulates blood sugar, and things that Bob had mentioned that are really important, especially the obesity. Having a lot of central obesity in the body can contribute to insulin resistance, so over time developing high blood sugar. So it's a great point, because I think a lot of people just assume I don't eat sweets, so why do I have high blood sugar? They don't realize it's their body kind of working against them at certain places because they have a lot of obesity around their waist. Now, Paula, let's go to you here. We just talked about the patients that are walking in the office that are just diagnosed with this condition. From a heart perspective, what do we see with diabetes?
Well, from working in the cath lab for many years, when you look at the vessels under fluoroscopy, they're very thin and scrawny compared to a normal vessel. And so before I even know that a person has diabetes, I can look at their vessels and say that this person is probably a diabetic. So it really affects them more than they realize. It's not just, like you said, as a sugar disease or a insulin disease, or it really affects their whole body.
Exactly, and when we say whole body, we know that it's not just the heart, because the body obviously involves all the joints as well. And speaking of the joints, Alyssa, why don't you tell us about how the feet specifically are affected by diabetes?
Well, specifically, we're looking at the very small nerves and blood vessels. Chronically high blood sugars damage them so they don't function appropriately. Oftentimes, people will come in with complaints of numbness, burning, tingling. Sometimes they won't even be wearing shoes, or they will just a light sandal or a slipper because they can't stand to even put a shoe or a sock on. And that's one of the first signs. I will often ask, are you diabetic? Have you ever been diagnosed with diabetes? And they'll say no. Perhaps I'll look at their family history and it'll say, mother died, complications of diabetes, father, heart attack, diabetes. Of course, there's other questions to ask. Be sure they don't have something like spinal stenosis, or perhaps they've had chemotherapy. That's another side effect, is that neuropathy.
But going to your point real quick here, I think that's great that you said about the family history, because people will say, they didn't die of diabetes, they died of a heart attack, but they had diabetes. They didn't die of diabetes, they had a stroke. What we want everyone to realize is that you can have all these conditions basically occur because of diabetes. Uncontrolled blood sugar for long periods of time can cause vascular disease, which can cause a heart attacks, which can cause a strokes. So it's a very good point, because a lot of people at home think, well, I didn't think diabetes caused that. He didn't die from high blood sugar, he died from a stroke. But that could have been ultimately caused by the high blood sugar.
And that's why as soon as I see them and my antennas are up for possible diabetes, I'm feeling for pulses, maybe their feet are warm, but I can't feel a strong pulse at the top of their foot. Boy, do I have a workup ahead of me. They're coming in complaining of burning to their feet and maybe an ingrown toenail. And now all of a sudden I have to say, well, when did you see Dr. Kozer last? Have you told him about this at all? No, he was just checking my blood sugar, blood pressure rather. Well, now you need your blood sugar checked. Do you have a cardiologist? No. So now I have a list of referrals just because somebody came in with one single complaint of burning to their feet. And now I'm sending them to you for vascular studies, sending a copy of my note to Dr. Kozer. Perhaps consider working up for diabetes, or I may even order a preliminary lab panel and forward it to the primary care physician, because that patient did not divulge that information to their primary care, so he doesn't even know what to work up if they don't tell him.
You're basically saying the toe is the veritable tip of the iceberg. Now, Alyssa, why don't you show us some things really interesting today of things that diabetics have in their feet?
Well, here's the problem, is that, as I said, people don't perhaps wear shoes because their feet are very sensitive, so they go barefoot. They're always barefoot. And when they have neuropathy, they can't feel that they've stepped on something. So I have a list today of top 10 objects my partners and I have removed from diabetics' feet. Number 1, glass. The holidays are coming up. I know whenever I have a party, somebody breaks a glass. I've gone so far as to go to Bed Bath & Beyond, and they have lovely glasses that are plastic, but they look just like glass. You break the glass, I might feel if I step on it, a diabetic may not. Weeks later, they come in, there's glass wedged up in their foot. Number 9, a rock. Yes, very thin slivers of rock can cut your foot, and then the other smaller pieces of rock can be in that wound as well. We've removed them. Number 8, a shell. We live in Florida. Shells are everywhere. We don't have gravel. We have crushed up shells. They can get up into your shoe. Same thing, I'm a broken record. It cuts your foot, and there's a blister underneath, perhaps an abscess. We've cleaned it out. We've taken shells out of feet. Number 7, a metal shard. After you've cleaned up that broken glass and you're going to the garage to throw away the glass, please put on shoes or you're going to step on a metal shard. Number 6, grass. We have sharp St. Augustine grass down here in Florida. My daughter can't roll in it down the hill like I used to when I was little. That grass can get wedged up into a callus. This has happened, called a fissure. There's a callus, and when there's a crack in the callus, that's called a fissure. The grass wedged up into the fissure, and who knows how long that was there before it caused an infection. These are all foreign bodies. Number 5, mulch. Do not do your yard work in sandals. Do not cut across the landscaping just because you don't want to walk to the sidewalk. The mulch can get stuck in your sock into your foot. Number 4, we're still in Florida. Palm thorns, quite common, causing small abscesses, and in fact, in one case, an amputation. Number 3, needles. Diabetics will eventually, potentially, be on insulin. They break off the needle, maybe it gets caught in the carpet. There's been a time where I took an x-ray actually ruling out a stress fracture of a patient's foot, and there was more than one needle in their foot. We just left them in there because to go after them would have caused more harm than good. Number 2, dog hair. Yes, there's something called a hair splinter. Hairdressers out there are familiar with this. When you cut the hair, it leaves a sharp edge. It gets just up underneath the skin, causing a blister that can get pus in it. And when they come in with their foot having pain, I will clean away or debride that skin. And what I pull out is a dog hair. I'll ask, do you have any animals at home? Short black hair perhaps, Dachshund? Yes, turns out to be. That can cause an infection. And the number 1 object removed, drum roll. Anyone? Thank you. A toothpick. Now here's the key with this one. Here's the interesting story. Diabetic, barefoot, toothpick in the foot. There was an abscess. We work very closely with infectious disease. And the bacteria that grew out of it, there were several, one of which was one called Eikenella, which is only found in the mouth. So even my infectious disease colleagues had never seen anything like this before. There was a mouth bacteria in the foot.
You know, you
Very
have to wonder
interesting.
that if they were utilizing a toothpick to pick something out of their foot and something got stuck and they, for whatever reason, didn't remove that piece of the toothpick that got
Yep,
stuck.
they may have.
Because
Yeah.
you'd think that it has it in their mouth, delivered to the foot, and that potentially might happen.
Yeah, and the point of this too is education. These all could have been prevented. All of them resulted in wounds, several infection, and a few resulting in extended antibiotics, multiple surgeries called debridements or incision and drainage of these abscesses, possibly an extended care facility. Please wear shoes. Please look at your feet every day.
And Alyssa, I think that's the main point here that we're talking about. It's not about the, hey, look what we found in people's feet. It's more or less this could have been avoided if they
Very
just
much
examined
so.
themselves.
All of them could have been avoided.
And again, you know, I have to go back to the point where I see as a vascular specialist a number of patients that we all see together that they come in from the wound care center or they come from your office with an ulceration of the toe or the foot, and you find out it's uncontrolled diabetes. And the A1C, the hemoglobin A1C for everyone at home, is the measurement of how long-term diabetic care is done. And it's sometimes difficult to translate sugar or high blood sugar to these types of ulcerations. Now, Bob, how do you find it difficult to get patients started on these medications, to tell them you're diabetic, number one, and then number two, get them started on either insulin or oral therapy?
Well, there's a tremendous amount of resistance from patients in going on medications for diabetes. First thing that I do is check their hemoglobin A1C. If it's greater than 6.4, that's a clear indication that they have diabetes. Or if their fasting blood sugar is greater than 125, or any random blood sugar is greater than 200, that's diagnostic of diabetes. Then the next thing I do, I check a urine microalbumin test. If they have positive microalbumin in their urine, then I know that they're going to be susceptible to kidney damage and plaque formation throughout their whole body. I try and educate these patients that they're about 80% likely to develop cardiovascular disease and that we have to use preventive measures. Now, the biggest preventive measure is getting their body mass index back down towards 25. If they can lose the amount of weight that's necessary to make them healthy, then they can actually protect themselves and prevent further diabetic damage.
And that's the thing, it's lifestyle changes, you know, a significant amount of times. Obviously, the type 1 diabetics, when we mean type 1 diabetics, the people that are diagnosed as children, basically who have to be on insulin because their insulin isn't there. But we're talking about older individuals who may have type 2 diabetes, who aren't working out enough, who aren't eating the right foods, who need to quit smoking. Now, Paul, let's talk about smoking. You know, vascular disease, diabetes, smoking, hypertension, these all go hand in hand. Have you had difficulty, like Bob has talked about diabetics, about patients being resistant to therapy?
Oh, certainly. A lot of people think that if they're just going to they quit. As soon as they have a heart attack, they'll quit right away. But then within 1 or 2 weeks, they're back smoking again. So it's really, you have to really educate these people. You have to actually show them pictures, what a good vessel and what a bad vessel looks like, and explain to them and tell them, I'm going to see you again. If you don't quit smoking, if you don't keep your blood sugar in line, you're going to be right back here in the hospital again, and we're going to be taking care of you again. So you really need to reiterate that. I know there's a lot of classes out there that people can take at the hospital. They offer diabetes classes. There's a lot of quit smoking. The American Cancer Society offers a lot of these classes, and we really need to engage the patient, but you need to engage the family, because it's very difficult for someone to quit when their spouse continues to smoke in the house, or, you know, so it needs to be a whole family involved in this education.
Well, let's go now to blood pressure control with diabetics. Now, Bob, do you have an issue with these patients as well, taking medications not just for diabetes, but for blood pressure?
The best blood pressure to have is 130/80. That's been documented in several long-term randomized trials. Now, it can be lower than that, but if your blood pressure is 130, that's just about where you want to keep it. Any higher than that, it puts you at higher risk of stroke, heart attack, or diabetic complications.
You know, the thing is, too, with the diabetic complications, I think that people underestimate what can happen. We're talking about all the potential downside, that if you don't treat yourself appropriately upside here by getting the weight loss, by the risk factor modification, you really can get yourself in a lot of trouble. Alyssa, how do you tell someone who just has a little ulcer on the foot, this could mean your life eventually? How do you hammer it in their heads that it's not just an ulcer?
Well, it's a fine balance between hammering it into their heads versus slowly, gradually, not overwhelming them. Because if you come in like gangbusters and say, see this blister? You could lose your foot, you could lose your leg. They're going to close you off. You have to start out simple by first educating them, controlling their blood sugar. It can be done with the holidays coming up. You want to watch the candy. It started in October September when the Halloween candy started. And from there, it goes into Christmas, Valentine's Day, Easter, Mother's Day. We have candy on the shelves from September to June because the Mother's Day candy is on sale. So you have to start out by educating them about that. Look at their shoes. Well, I see the shoes you're wearing now. Those aren't appropriate. Here's some other answers. And then once you go through that, you don't want to show them pictures of people, with amputations, or perhaps they'll wait in my office and see somebody limping out with crutches. They've obviously had an amputation, and they'll say, what happened to that guy? So you have to start out very, very slowly, but give them tools to prevent this from becoming a further complication. Wound care, home health involved, see what their family support is. My dad said, you don't know what you don't know. So I tell them that phrase, and I say, well, now you know. He is. If you tell them that, once you've told them, now they know. But now don't come back to the next visit, and now there's grass, dog hair, cat hair, shell in your wound. If you had a shell,
while chewing a toothpick.
Yeah, chewing the toothpick, cleaning out your wound. If you come in, and I've already seen you a few times, and you have a wound, and now there's foreign bodies in the wound, now you get a talking to. Now I got to lay the line down.
And Alyssa, what kind of shoes, now this is a question I get a lot in the office, what type of shoes are suggested for diabetics who have had, just say, a small ulceration in the toe, even the ones that have had no problems in their feet? What would you suggest?
Okay, well, first of all, if they haven't had any problems in their feet, well, once they're diagnosed, of course, they should really get at least a yearly or 6-month podiatric exam at minimum, and then, we'll see any potential complications. If they have had a complication, like an ulcer or even an amputation, then if they are within Medicare age, or some private insurances will pay for 1 pair of shoes and 3 sets of custom molded inserts. They will pay towards that, about 80%. So you really need an evaluation for your proper shoe size. As we get older, our feet get longer and wider. Women, after they've had children, their feet get wider as well. You need to be measured every year. But I really don't recommend that they go on their own to look for shoes. There's Fit to Run, New Balance. We have some really good stores around here to help evaluate that.
How about high heels for women?
Now, I don't mind high heels. Diabetics with high heels, they really don't mix. However, if you're diabetic and you're very well controlled and you don't have neuropathy or peripheral vascular disease, if you're going to wear any kind of a heel, no higher than 2 inches, preferably a wedge, so it distributes the pressure evenly. Other than that, do not come in with a toe amputation and a pair of high heels.
This wouldn't look good. Just doesn't look very good.
No, just might as well,
Well, Bob, let's go back to the vascular issues other than the extremities in diabetics. Now, we talked about the heart, we talked about strokes. Let's talk about a subject that's truly unsexy in a lot of ways, erectile dysfunction. Do you see a number of patients in your office that are diabetics that have ED?
A great proportion of my diabetic patients will go on to develop erectile dysfunction, and that's often a big clue if a man comes in and says at the end of the visit, oh, by the way, doc, I'd like a prescription for Viagra. Well, I will always tell them I would be happy to discuss that with them, but we really need to discuss the reason why you're having erectile dysfunction, and usually it's due to some insulin resistance problem, and we need to check their blood pressure, their cholesterol, their triglycerides, their A1C, the microalbumin, and then they have to have a complete vascular examination like an ankle brachial index. Often they need to have an echocardiogram, they need to have their aorta checked with an ultrasound to be sure they don't have aneurysm. it's really a big job.
And that's amazing that you said that, because I think people watching right now might say, I just thought it was erectile dysfunction. The guys in the commercial seem to be running up and down the beach having no problems, but that's true. ED is usually a sign of something a lot bigger going on in the body, whether it be diabetic complications, vascular complications, spinal issues, something is going on that's causing it. So that's an important point. Just like mentioning the tip of the iceberg with the toe, a lot of times the body's trying to tell you something. There's something else occurring. You know, there's something else going on.
And it shouldn't be something that they mention as they're walking out of the room. For instance, in my case, they come in with heel pain, and then as they say, and I've had some numbness. I mean, we have a form to fill out where they check off their symptoms, and you know, it says numbness, any burning, any tingling, you know, something like that. But if it's going to turn out to be a major workup, we don't mind doing it, but we really implore people to tell us the important stuff in the beginning. Or if you're not comfortable with your spouse coming into the room, leave them in the waiting room. And if there's something we need to bring them in, if you have a wound and I need to show your wife how to do the wound care, we'll bring her in. This isn't something that you need to be afraid to talk about on any level.
And that's a great point as well, that you mentioned spousal support or familial support. Paula, when you found patients who've had these major vascular complications, let's say down the road they've had these massive MI strokes, but after they're treated with the initial stent or whatever surgery they need at the time, what is the family support situation?
The patient is usually afraid, so they're scared. And then the wife is usually, or the spouse is afraid also. So the one will pull you apart and ask you, can we do this? Can we have sex? You know, is he going to be okay? Is he going to have a heart attack if we ever have sex again? You know what I'm saying? So these are things that they need to feel comfortable with talking to the doctor, talk about the medications they're on, if that's going to infect them, if that's part of it, if there's other problems that's causing it. So you really need to be able to talk to them. They need to feel comfortable with talking to their doctors and talking about it.
Well, I think dietary issues are, extremely important. Obviously, having a correct dietary guideline to go by, because it's not just diabetics that we're treating here. We're treating vascular, we're treating hypertensives, we're treating people with a number of other issues that are going on. Bob, do you have any suggestions for dietary guidelines for these types of patients?
Yes, I do, especially for the pre-diabetic patients or the diabetic patients. Obviously, they want to avoid carbohydrates, especially sugar. Now, the other thing that I tell them that they don't need to be so concerned about the fat content of their diet, except I do believe that the polyunsaturated fats are really the bad characters in this whole picture.
That's what they should be looking at.
Avoid the margarines, the corn oils, the vegetable oils, and really, I think the saturated animal fats have really gotten a bad rap. I think that it actually is somewhat protective to cardiovascular disease. Use butter instead of margarine. Use olive oil instead of vegetable oil. And also, the benefits of coconut oil are so important too.
Yeah, and that's another, we can have another topic, another 30-minute segment on that anytime, because I think it's really interesting. But guys, we're coming close to the end of the segment here. So Alyssa, want to give some final thoughts?
Sure. Don't be afraid to talk to us about any issues. We're physicians. It's confidential. Please put that you're on Viagra, even if you're coming for a toenail exam. I need to know if you have vascular complications. Get your feet checked at least once a year, perhaps every 6 months. Look at your feet every day. Don't just say, yep, they're there, all 10, I'm good. Get a mirror, look at the bottoms of your feet, and don't be afraid to call your podiatrist.
So are pedicures covered under Medicare for people over 65? Because, you know, a lot of people, older people, they try to clip their own nails and they end up with an infection or something.
It's what we consider at-risk foot care, and they do have to meet certain criteria. So it's one thing to come in and get evaluated. An evaluation is covered, and then we'll let them know if they meet the criteria for at-risk foot care.
Well, Paul, any final thoughts?
I think that it's the holidays are coming. People need to eat in moderation. And some people, they try to exclude all the sugars or all the fats, and then they binge. So we need to let them know it's okay to do a little bit, just not a lot. Moderation. We really need to, enforce that, or let them know that it's okay to do a little bit, just not the whole box of candy, not the whole pound of butter.
You know it. And Bob, we have a special event here at the end of our segment. I'd like to tell everyone at home that Dr. Kozer is the current champion of Dr. Idol, and he's here to finish off our program today with a little song here. Four-time champion, yes, but current reigning champion as well.
Yay.
Thank you. I woke up this morning, got out of bed. I had some pain. It hurt my head. I couldn't get up. I dialed 911. The doctor, he told me, just look what you've done. I've got the broken heart blues. Don't live your life in a nursing home. Now I'm laying here praying about my broken bone blues. I'm afraid I'll be stuck here, but that's not the bad news. I wished I'd have listened to the doctor that day and taken them pills. But I said, what the hey, I've got the broken heart blues. Don't live your life in a nursing home.
All right, excellent.
All right, don't forget to take your statins and your ACE inhibitors and your metformin.
And that he does that in every visit in his office too. So guys, come on and see Bob.
Thank you.
So folks, thanks a lot for watching today. And like I say, thank you to all our guests for joining us today. While diabetes is a serious chronic disease, it can be managed through lifestyle change and medication. As always, remember, a positive mind is a positive body. We'll see you next time on the Pulse of Manatee.